It's a real pleasure for me to be here to share with you the experience we have in Quebec for almost 2 years now with medical assistants in dying, and mainly the experience we have, my colleagues and I, at the hospital I'm working at, which is a major teaching hospital located in Quebec City. So let's start with the disclosure slide. I want to make it clear that although I'm board member of the Quebec College of Physicians, I'm not talking on behalf of the college today. So I'm talking on my own name, and it's the same for the hospital I'm working at. I have no conflict of interest with the topic of this presentation today. Second, as you can hear, English is not my first language. Nor it is the language I use to work, so I'm going to show some compassion for me. If you hear something that sounds weird, it might probably be a French or Spanish word or expressions, but it's usually pretty close. Here's the plan for today's talk. So let's start with some information about our provincial law, Quebec Bill number 2, which is called Loi sur les soins de fin de vie, an act respecting end-of-life care. And the link is in English if you want to have an eye on it. So, quick historic backup. December 4th, 2009, government set up a special parliamentary commission that was called Mourir dans la dignité, dying with dignity. This commission went all around the province for 5 years and did a tremendous job, going everywhere, hearing whoever wanted to be here on this question. And it all ended up when June 10th, 2014, with the bill that was passed with 81% of the parliamentaries in favor, no abstention. And it was a free vote, no party line at this moment. The government gave us 1.5 years to set up whatever needed to be. It all took effect December 10, 2015. We started to offer MAiD to our patients all over the province. Bill number 2 is not a bill on the medical assistant in dying only. It's a bill on the end-of-life care. So it includes chapters on palliative care, medical assistance in dying, of course, palliative sedation, and advanced medical request. That excludes MAiD, as you well know. Let's see main differences between Bill number 2 and C14 that you know well. In our provincial law, the patient must be at the end of his life. There's no definition in the bill of what is end of life, no time lapse. But clearly the patient must be on a downslope with an unavoidable death at the end. Might be 2 months, 6 months, 1 year, maybe more, but we're talking about end of life. Clearly the severe chronic patient, severely ill chronic patient is not eligible to medical assistance in dying. There is no 10 days mandatory waiting time. Assisted suicide is not permitted. And nurse practitioners are not allowed to assess and provide MAiD. Even with C14, you must know that the legal frame for nurse practitioners in the province is quite different from the one in the rest of Canada. So they're still not allowed to assess and provide MAiD. There's a mandatory declaration form to be filled within 10 days of MAiD providing and sent anonymously to 2 places. One is a governmental commission set up to study these forms and to do statistics out of them, which is called the End of Life Care Commission. And the other one is the Council of Physicians in each hospital to study them from the angle of care, quality of care. There's never a coronary inquiry, and all public health institutions must offer MAiD. Not may, must offer MAiD. It's mandatory. So it's available all over the province. Must be end-of-life condition. So we're in the province in kind of foggy situation where we have two laws and the guidelines done by the Supreme Court of Canada, and the three are saying different things. And we still rely on the end-of-life definition to accept a request. Why so? Because we know what end-of-life is, and we're comfortable with it. We don't know what a natural, foreseeable death with no prognosis necessary means exactly. It means whatever you want it to be. So, as I always say, my own foreseeable natural death is within 28 years, based on my actual age and life expectancy. Am I eligible to MAiD? I hope no. But someone could state that I am. So we're not comfortable with this, and we still stick on this provincial definition of end of life. And yes, some patients are penalized because we're much more restrictive that the Supreme Court of Canada would like us to be. And some patients pay for it. All public health institutions must offer MAiD. There is one exception in the law, and these are the hospices. Hospices, there are 31 of them all over the province, and they're, well, private institutions with private funding for most of their funding. And at the beginning, all the 31 said, we won't offer MAiD, and they were allowed to do so with the law. But since then, 3 have changed their mind. They just conducted surveys among the population they served and among the employees, and 90% of them said, well, we would like you to offer this care. So they just got patient-centered instead of ideology-centered, and they've changed their mind. There's a new one that will open up this fall in Shawinigan, which is the country of Jean Chrétien, the 32nd in the province, and it will offer MAiD. Two more differences. In Quebec, the doctor who assesses a request must provide MAiD himself. I know it's not the case in every province. And for the official request form, the patient needs 3 witnesses when he signs this form. 3 witnesses. Because the quality of the witness in the provincial law is different from the 2 in the federal law, so the lawyers got no better idea than mix up all the 3 witnesses. So let's begin with some statements about medical assistance in dying. Medical assistance in dying is a clinical, medical, moral, ethical, legitimate, and completely legal care. It's given in full respect of the patient's will, needs, and beliefs, and it's provided with compassion and humanity. MAiD is not a shameful care. No patient has to hide from asking MAiD, and no caregiver has to hide, justify, or excuse from being involved in MAiD. MAiD is everything but a simple lethal injection. If you think that MAiD can be summarized with the 8 minutes injection time, you're completely wrong. For me, the most important part with it is not the 8 minutes technical injection time. It's the 8 hours I'm going to spend with this patient, his family and relatives, to guide him toward an unavoidable death. MAiD is an accompaniment of a suffering and hopeless patient. There is no opposition between palliative care and MAiD. What are the options available for a patient facing death? There are not dozens of them. There are 4, actually. Could opt for denial of care. Could opt for palliative care. We know what palliative care is. Could opt for medical assistance in dying or terminal sedation. And which one is the best one? I don't know. I don't know which one is the best one. Personally, I'm in favor and against all these options at the same time, in the way that I'm against suffering, and I'm in favor of the total respect of the patient's will, needs, and beliefs. And I could say, well, which is the best option? It's none of my business. It's the patient one. You know, as a palliative care doctor, when a patient is told by his specialist, cancer patient, I can do no more for you, I'm sorry. We palliative care doctors meet these patients and tell them everything remains to be done. And we're going to do it together. And I'm going to be with you until the end. I'm going to hold your hand until the end and take care of your family and relatives at the same time. And as a palliative care doctor, I feel I have no right to let him down, to give up to this patient, because at the end of his life, facing death, he's going to choose an option that is completely legitimate and legal. This is my work. I promised him to be with him till he dies. So I have no right to give him up. Again, I don't know what's the best option. MAiD is in no way against palliative care. With palliative care and other end-of-life options, MAiD is for the patients. It's not against anyone, it's for the patients. MAiD is an end-of-life accompaniment. I strongly believe that the only worthy death with dignity is the one a well-informed and competent patient will choose freely for himself in accordance with his own beliefs, values, and IDs. What the Supreme Court of Canada told us with his Carter case? Well, in summary, Supreme Court said the right to live must not be transformed into an obligation to live. For those with incurable illnesses and unbearable suffering. Supreme Court did not mention end of life, even less natural foreseeable death with no prognosis necessary. And it's kind of ironic that Mrs. Carter wouldn't be eligible to MAiD if he were still alive today. It's easy to debate or philosophize over the meaning of death and suffering when others are facing it. Let me give you some information about the hospital I'm working in, just to help you to put these numbers, some numbers in perspective. So it's called Centre Hospitalier Universitaire de Québec, CHU de Québec, Université Laval. And it's a joint of the 5 largest hospitals in Quebec City. It's located in Quebec City. It is actually the largest health institution in the province. It's not in Montreal, it's in Quebec City, and the 3rd one in Canada. 2 million population served, mostly east and north of the province. We've got a council of almost 1,700 doctors, physicians, and dentists, and 1,700 beds. 300 of them are under the administration of another hospital now, but still within our hospital. We've got 4 palliative care units, 5,800 patients, cancer patients hospitalized each year. 2,700 deaths a year. So it's an average of eight patients a day. 2/3 of these patients were receiving palliative care. How many patients? I go to the next slide. In 2016, a full year, 85 patients died with medical assistance dying in our hospital. That means was 2.1% of all patients who died within our walls. Up to this month, 115 patients. Still the same rate, 2.1% of all deaths. So it remains an uncommon, an exceptional care in all countries who are offering MAiD for many years, like Belgium since 2002, Switzerland, Netherlands, much before. They've reached a steady state of between 2 and 4% of patients who die with medical assistance and dying. Of course, it increased over the first few years, but it has reached a steady state. And if we talk about the province, 2016, full year, 461 patients, was less than 1% of all deaths with medical assistance and dying in that year. So we're expecting an increase of these numbers for 2017. Who are these patients? About 80% of them are terminal cancer patients. The remaining is divided into 3 groups, mainly cardiac, pulmonary, and neurodegenerative illnesses, mainly lateral amyotrophic sclerosis. Who are the doctors who got involved in MAiD to assess and provide medical assistance in dying? Well, we have many doctors. Of course, a family physician, palliative care doctors, surgeons, anesthesiologists, emergency doctors, hemato-oncologists, endocrinologists, ophthalmologists. We got an ophthalmologist lady who was doing a tremendous job in meeting these patients and their families. And I must say that all our palliative care doctors, there are about 40 of them, they're all involved in MAiD, whether it is to assess and provide MAiD themselves or to give the second advice. And since the very beginning, MAiD was completely integrated in our palliative care units into a comprehensive end-of-life care offer. Some other places, not in Quebec City, but outside, I've said at the beginning, well, in our palliative care unit, we won't offer MAiD. If a patient asks for it, we will move him into another ward. First, they have no right to do so. It has been corrected rapidly. Second, we bet they were wrong, and we were right. And I'm going to tell you why. And they said so, I forgot to tell you, because they said, well, we don't want to mix up patients of what we're doing on the palliative care unit. But we bet that will not be the case, and we were right. I'm telling you why. We're struggling for decades with patients to bring them into a palliative care ward. And I'm sure you know what I'm talking about. Why so? Partly because patients think that once they're on the palliative care unit, they will be euthanized without them knowing it. Moreover, I met a lot of doctors who told me, well, euthanasia has always existed all over Canada, even if it was prohibited or forbidden. It has always existed. I've seen some. I did some myself. So that was feeding the fears for these patients to get euthanasia without them knowing it if they move to the palliative care unit. Now, everything is crystal clear for everyone. So no patient fears to receive euthanasia without knowing it, by the back door, under the table, under the blanket. It's crystal clear. And for the doctors, for the patients, for the nurses, for their families. See what palliative care is all about. See what terminal sedation is all about. See now what medical assistance in dying is all about. If you want to receive medical assistance in dying, there's a procedure. There's a formal request form that you're going to have to sign in front of 3 witnesses. You're going to have to meet 2 doctors. Better have good reasons, because it's not available to anyone for any reason. And all the caring team is watching all the process. So no one received MAiD without knowing it now. So it helped to calm down all the apprehensions of the patients and of the nurses, of the caring team also. So it's not a problem to provide MAiD. It's part of a comprehensive end-of-life care service for all our patients. Let's talk about some myths, falsities, and misconceptions about medical assistance in dying. First one, physical suffering means physical pain only. And its variant, well-controlled physical pain eliminates request or eligibility of a patient for MAiD. That's false. Physical suffering is also everything like this. Cachexia, that's the shortness of breath, dysphagia, paralysis, bed resting, wounds, exhaustion, bowel occlusion, hemorrhage, repeated procedures. And physical pain is very uncommonly the main issue for a patient to request MAiD. Psychic suffering is by far the most common issue, and we've seen that it's present to everyone, every and all of these patients who ask for MAiD. And most of them, for sure, have got also physical sufferings. Next. Patient who receives good palliative care never asks for MAiD. You've heard that, I'm pretty sure. And its variant, requests for MAiD are the sign of a defective access to good palliative care. That is totally false. Do we prescribe terminal sedation because the patient is not having good palliative care? Of course not. In the same way, we don't offer MAiD because the patient doesn't have access to good palliative care. Our experience at the CHU de Quebec, between 80 and 90% of our patients were already under super good palliative care. We got specialized and over-specialized teams for palliative care in our hospital, and they're receiving top-notch palliative care. They ask for MAiD. And the remaining 10 to 20% just refuse to receive palliative cares. So they take the option, freely, well-informed, not to go into palliative care. And you know what? They've got the right. So there's rejection of palliative care by some patients. I'm not there to put them absolutely into palliative care. I'm there to inform what are the possibilities, what are the options, what are we going to do. But at the end, it's the patient's choice. Another proof. I told you about the 31 hospices in the province. 28 of them still don't offer MAiD. But in every institution, in every hospice, there are still patients that ask for MAiD, even if they knew that it wasn't offered. They have to sign an engagement form when they ask to go there, in which they recognize that MAiD is not offered. It can be a request. But it's one thing to sign a form 4 months before death, and well, to become facing death with unbearable suffering, and to say to your doctor, I can't stand it anymore. So they're told at these places, well, we can put you asleep and watch you dying slowly. Take it or leave it. We have no other option. The patient said, well, this is not the way I want to end up my life. This is not the option. I can't stand it anymore. I want to end it up rapidly, quickly, peacefully. I want MAiD. What they do at that moment, they get rid of the patient, put him in an ambulance, and they move him in our hospital. Whether the patient is going to die with MAiD, with strangers, strangers, and in an unwanted place. This is shameful to me. Good palliative care are essentials. Let's be clear, I'm a palliative care doctor. We must offer good palliative care everywhere. It's the basis of end-of-life care. But it can't relieve everything. I'll give you an example. Told you about these hospices. The first one to open in Quebec, and the most renowned of them, is located in Quebec City. It's called Maison Michel Sarrazin. It, so far, doesn't offer MAiD. At this place, every year, between 5 and 10% of their patients die with palliative sedation. And you know that when we prescribe palliative sedation, things are not going very well. Patient is in distress, and good palliative care can't relieve anything. Next, it's forbidden to talk about MAiD to a patient unless he asks specifically for it. It's false. And on the contrary, it's an offense, professional offense, to deliberately hide a care that's legitimate and legal. So we got the obligation to bring up MAiD into discussion when it is appropriate to do so. So if you're talking about end-of-life options with your patients, and you talk about palliative care, talk about terminal sedation, and you deliberately hide the possibility for him to receive MAiD, it's to me an offense. So we got to inform the patient of available options, make sure of his understanding with no judgment nor influence, and respect the patient's choice. Next, obligation to set up a date on the assessment visit, false. We do have to assess the eligibility, and on follow-up visits, make sure that the patient is still able to consent and has not changed his mind. Patient must have tried everything before. Patient must have received palliative care before. No. We have the obligation to inform about alternatives and possibilities, but the obligation to respect the patient and his choice. The patient is the only one who can bear witness of his own suffering. We owe him our total respect. Mandatory 10 days waiting time? No. No such thing in Quebec law. And, well, we'd say 14. Don't forget that there's 2 exceptions possible. One of them is the risk of losing ability to consent, which you can find in all your end-of-life patients. So you don't have to stick on this criteria. And it's up to the assessor and second professional to decide. So we should stop saying to the patient, he must wait 10 days. 10 days for the terminal cancer patient. Wait 10 days is not only lack of humanity, it's cruelty and sadism, believe me. If we talk about severely ill, chronic patients, wait 10 days would look fine. Better wait 10 days here than take 4 months to go to Switzerland to receive assisted suicide. But for cancer terminal patients, makes just no sense. Agreement of families and relatives is necessary? No. It's up to the patient to decide. Some family members, relatives, are having a difficult time with MAiD. Uncommon, but true. We're still talking about death. Death will always be a difficult and unpleasant and painful experience for the family and the relatives. If you have never seen pathologic mourning, it's because you're new in practice. Pathologic mourning, dysfunctional individuals and families have always existed and will always exist, with or without MAiD. MAiD hasn't been introduced to relieve families, friends, and relatives. We have the obligation to protect the ill patient first. The patient is the boss. We have no such experience in Quebec City, but I've heard of some in Montreal mainly, few of them, but some, of the families threatening the patient who signed a request for MAiD with things like, if you don't withdraw your request, we won't come to seeing you anymore. This is horrible. And we have the right to protect these patients because MAiD is there for the patient, not for the family. Of course, we care about the families, but not at any price. Assessment and accompaniment. Let me talk a little bit about Marie. Marie is not the first patient I had the privilege to meet, but she's one of the first patients I met. And almost 2 years later, I still keep on talking about Marie. Why? Because I think she summarized everything we can find with these patients, cancer patients, that ask for MAiD. So let me introduce you to Marie. Marie is 63. She's married for 42 years. She lives with her husband. She's got one daughter, 36, one grandson, 5. Her daughter is a social worker. She's a manager. She works in a large financial institution. She's practicing Catholic. And 10 years ago, she changed her lifestyle completely. She quit smoking, care about her alimentation, and start to run. She's athletic, she's fit. She used to run many 10 kilometers every summertime. February 2015, she's diagnosed with cancer, pulmonary cancer, stage 4. And you know what stage 4 is. With neoplastic pericarditis and tamponade. Mary wanted to live. So she's young, she's happy, she's having a fulfilling life. She's going to take everything we will offer to take a chance to live, to cure this cancer. So during the year of 2015, she's going to go under 3 different lines of chemotherapy, including experimental one. December 15, 2015, she arrives at the emergency room with a bowel occlusion. She's hospitalized in the oncology ward. December 23rd, left pleural effusion, we put a pigtail tube. December 24th, she asked to stop chemo. Mary is clever. She knew that she was to die. Level of care number 2, which means in our hospital we keep the IV line, hydration. Mary wants to spend, for the last time, holidays with her family. We ask a consultation with the palliative care team. Mary is a clever lady. All during the fall period, she showed her husband how to do the cleaning, how to do the laundry, how to do cooking, for him to be autonomous when she's going to leave. And why she wanted to spend, for the last time, holidays with her family? Of course, this period of year is important. But during this time, she made a comprehensive 1-year planning, written planning for his husband, with more details, many details, like July 1st, don't forget to pay that bill. May 15, you got to call this agent for renewal of the contract, and so on for many pages. So, on return of holidays, January 5th, she asks level of care 3, which means comfort care in our hospital, and Marie's transferred to the palliative care unit. Her current state at this moment. She's bedridden completely, unable to eat or drink, of course. She has lost almost half of her body weight. She's like a skeleton. totally bald, many tubes going out of her body, peritoneal carcinomatosis and occlusion with a belly that high, ascites, countless metastases. On the radiologic exam, the radiologist just said, well, there's too much to have a number of them. Prognosis is less than 3 weeks, and probably less, of course, if we stop hydration. I'm pretty sure you can have a picture of Mary in the back of your head at this moment. Medication, not much. If you do palliative care, it's usual stuff. Hydromorphone, 0.6 milligram each 4 hours. The rest for nausea, help her to sleep. Not much of medication. Physical pain is quite under control, but she's having physical suffering, for sure. Totally bedridden, extreme weakness and muscle wasting, unable to eat or drink. She's got a gastric tube for almost a month now. Many uncomfortable tubes going out of her body. But the worst is psychological suffering. Loss of body image, loss of dignity, completely dependent on others. And you can figure out that Mary is not happy to be dependent on others. And the remaining time is virtually meaningless and worthless for her. Thursday, January 7th, she signed her request form asking for MAiD. At that moment, she has already discussed the subject with everyone she wanted to. The family, of course, palliative care doctor, the oncologist, social worker, even the chaplain during holiday period time. And she receives unconditional support from her family. The same day, I was called to meet Marie to assess her request. Usually I meet these patients the same day or the next day at the most. Cannot go to see these patients 2 weeks later. It's too much. But that evening, I wasn't free, unfortunately, so I met her the next day, Friday in the afternoon. Marie was already in a private room. They must be in a private room. And the encounter will last a little more than 2 hours and a half. It always takes between 2 and 4 hours for me. 4, 5, maybe comes up to 5 hours in certain cases, but usually it's 2 to 3 hours. Got to read the file, got to talk with the treating physician, social worker, the nurse. I got to meet the patient, of course, meet the family, write the notes. So it takes many hours, this assessment. And there's an involvement of all the care team. It's not only rely on my own shoulders. So I got to talk with everyone. When I asked Mary, when do you want to receive MAiD? Her answer was tonight at 8 o'clock. We were at 5 o'clock in the afternoon. She wanted at 8 o'clock. At first, I was struck with these answers. They all wanted to receive MAiD the same day. But after 4 or 5 patients, I then realized that when these patients asked for it, they already talked about it with whoever they wanted to do so. So they're ready. They've been through the suffering, the loss of dignity. And when they say, well, that's my choice, they want it now. So tonight, 8 o'clock, she said, well, you're there, I'm here, my family is here, we're all ready, let's do it. So I explained to her that wasn't possible the same day, of course. And at the same time, I realized that I couldn't tell Marie, well, we're Friday afternoon, tomorrow is weekend, you know, Saturday I usually go to the restaurant having breakfast with my wife, and we have planned a nice walking downtown Sunday. I'm out of duty Monday, so I'm going to come back Tuesday and we'll talk again about it. Couldn't answer that to Mary. So I told her, well, give me half an hour. I have phone calls to make. Going to try to find a second doctor. We need a second doctor. Going to phone the pharmacist. If I could set something for tomorrow, would it be okay for you? And she said, yeah, okay, let's do it, but sooner possible. Who do you want to be with you at that moment? My husband, my daughter. That's it. So I quit the room, make my phone calls, and came back 30 minutes later to tell Marie, well, everything is set up for the next day, Saturday at 11 o'clock. Would it be fine for you? She said, okay, great, we have a deal. She made special request. She said, well, you know, doctor, I'm here for almost a month now with that tube in the stomach. Tomorrow, before we do it, would it be possible to take out this tube and let me have a coffee from Palliard? Palliard's a well-known coffee shop near the hospital, and let me have a toast with strawberry jam. For almost a month now, every time I fall asleep, I'm dreaming of eating a toast with strawberry jam. I said, why not? We'll see tomorrow. So for Marie, it was clearly a matter of empowerment. And she said it clearly to me. You know, over the last year, everything was under control of the illness. Well, the visits, the treatments, the side effects, the exams to pass. I know I'm gonna die. I want to take back control on my own end of life. Marie's that person. You have noticed that. And for her, it was a question of dignity. Of course, we have to manage the family. I always meet the family to explain what's going to happen, what they're going to see. We must do it. It's important. Funeral home. And I've learned that, well, the next day after she died. Her daughter told me, Doctor, yesterday when you left the room at 5:30, do you know what Mother did? I said, no. She said, she picked up the phone, she called the funeral house and told herself, the lady, tomorrow by the end of the afternoon, you can come over and pick up my body because I'm going to be dead. And I'm telling you that just to show how convinced and determined these patients are. When they take the decision to go for MAiD, the game is just over for them. So the next day, her daughter and husband spent the night with her in her room. I always come 1 hour before, for many reasons. Just, well, to reassure the patient and the family that I'm there. So I won't be late. You cannot be late for that moment, of course. Just to check if patient has changed his mind, check if she's still able to consent. And at that moment, she was stable, so we removed the gastric tube. She had a central IV line. Otherwise, we put a IV line in the elbow, and let her have her coffee and toast with strawberry jam. Family has brought champagne, so they shared a glass of champagne with Marie. I left the family. Meanwhile, I'm going to the pharmacy to pick up the drugs I need. And I'm always back at bedside 5 minutes before the moment we set up. There were supposed to be 2 members of the family. Finally, there were 11 of them. Marie invited some other members to share this moment with her, and the nurses was there also. So at 11 o'clock was a time for last farewells, hugs and kisses, whisper words in the ears with everyone of the family members. She was totally serene and peaceful. We've been through a last confirmation of consent. Then she turned her head toward me and told me, well, doctor, I'm ready. Let's begin. Procedure. It's always a strong, moving moment, the procedure. It is for us, doctors, of course. It is for the family, relatives. But when I go back, because after the procedure, when I tell the family that the person is dead, I quickly get out of the room. They know that. in advance, because I believe this moment is for the family with the patient. But I always come back about 15 minutes, 20 minutes later on, and can tell you that the moment of the procedure is a very emotional moment, but when you come back 20 minutes after, the relief of the family is at the same level. These are the drugs we use in Quebec for the procedures. Standard procedures, always the same for every patient. Mainly 3 drugs, midazolam 10 milligrams, that I inject in 20 to 30 seconds. Propofol, 1 gram. If you use propofol, you know what kind of dose it is. We inject over a 5 minutes period, and the neuroblocking agent, cisatracurium, over 30 seconds. We start with the saline injection, just to make sure the IV line is functional. So this is the syringes we got in the box. We bring 2 boxes with us. The second as a backup, we never use it. And in each box, we've got 4 syringes of propofol. We use 2 only. What happens if you're at the bedside is when I start injecting midazolam over 20, 30 seconds, it takes about 1 minute for the patient, 1 minute and a half at the most. He's going to blink his eyes and fall asleep. Then we have xylocaine, 2 milliliters, and push before the propofol, because could be irritating to the vein. And when we start propofol, first syringe, after 10, 15, 20 milliliters of propofol, patients just stop breathing. So we're 1 minute later on. So it's a matter of about 3 minutes. Patient falls asleep and just stop breathing. There's no movement. There's no sound. There's no respiratory distress. There's no incontinency. I always tell that to the patient and the family, because this is dignity. Patient is asking, well, gonna do it in front of my family. Will I have fecal or urinary incontinency? The answer is no. We must tell the patient. We give all the medications. It takes about 7, 8 minutes. And then we just put our stethoscope to make the attestation of death. On the official death certificate, the cause of the death is always the illness. We cannot write medical assistance in dying in the hospital file. Of course, we write it, but the official death certificate is always the illness. And it makes sense. Marie did not die from MAiD. She died from her cancer. What does MAiD bring new or different to patients, families, and relatives, to caregivers? I believe this is the most important slide for today. And you have noticed it's not written better. Again, you will never hear me saying that MAiD is the best way to die. I don't know what is the best way to die. But it brings up different things from what we used to meet to know. First, insurance policy. It acts actually as sort of insurance policy for ill patients and good health patients. People are saying now, well, I don't know when I'm going to die and in which way I'm going to die. But I know for sure that at that point, if I'm having unbearable suffering, I won't have to tolerate everything to the last breath. Relief, appeasement, and pacifying to these patients. We all seen that in every patient. From the moment you tell them that they're eligible, we're gonna receive MAiD tomorrow or whatever in 2 days. The patient is really relief and appeased. They're not fearing that moment. The fear is that it will be postponed. The doctor will not show up. They're looking for that moment. I had a bit of trouble understanding that at first, but then I realized that for these patients, no patient asks MAiD for no reason, for a trivial reason. It's not commonplace. And for them, it's really the light at the end of the tunnel. they can say, now I know exactly what day, what time my suffering is going to end up. Empowerment. Marie is a good example of that. It always avoids terminal coma, agony stage to all these patients, of course. It allows planning rituals of this moment with relatives. All the people the patient wants with him at this moment is there. They can plan to be there. Communication capability preserved up to the end. Last word, farewells, hugs, kisses possible with family and with caregivers. It's important for us too, and for the patient. Less guilt for families versus terminal sedation. Only the patient can ask for MAiD, and he's got to sign for it. Terminal sedation can be authorized by family. Sometimes family feel it with guilt. Well, you want me, because the patient is in comatose state, you want me to sign, gonna put to sleep my mother, my father, whoever is gonna die. I don't know if it were his will, really. And they feel it with guilt. Doctor always at bedside with patient and relatives. I'm doing palliative care for 31 years now. Can count. I have too much fingers on my hand to count the number of times I was at the bedside of my patient when he passed out. Usually it's the nurse, family, very often nobody. I'm always there with these patients. And relatives witness a rapid, peaceful, and painless death as the patient wanted it to be. 2 papers that's worth reading, my opinion. Of course, we had a lot of papers in the province of Quebec over the 6 past years. I wrote many myself. They were all in French, of course. These 2 are in English, if you're interested. This one is about conscientious objections by doctors, written by 2 renowned ethicists, one from Queen's and the other from Oxford. The place to debate issues of contraception, abortion, and euthanasia is at the societal level, not the bedside. The other one is about the institution with the possibility to opt out. It's not a case in the province of Quebec, as I told you. This is the words of an old lady we had who was a devoted practicing Catholic and asked for MAiD. And she was asked if she wasn't seeing any contradiction between her religious beliefs and her request for MAiD. And she answered back, well, if God cannot understand that, I don't feel like spending the eternity with him. And I'll end up with 6 keynotes. MAiD is a medical, clinical, moral, ethical, legitimate, and completely legal care. MAiD is not a shameful care, which one must hide, justify, or excuse from. MAiD is everything but a simple little injunction. It's an end-of-life accompaniment. It's easy to debate and philosophize over the meaning of death and suffering, but others face it. No patient must pay with his own suffering the price of religious, ideological, or personal values, beliefs, and convictions of some caregivers. Strongly believe in that. There is no opposition between palliative care, terminal sedation, denial of care, and MAiD. They're all legitimate and legal end-of-care options, which the free and informed choice belongs exclusively to the competent patients, in accordance with his own values, beliefs, and convictions. Many individuals would like to be involved in the final decisions of the patient. Tell him how he should die. Some doctors, mainly opponents, or doctors with personal, ideological, or religious beliefs. Lawyers, ethicists, philosophers, priests, bishops. I would say just listen to the patient. Don't talk, just listen. He's going to tell you how he would like to end up his life and what dying with dignity means for him. I don't know what dying with dignity means. The patient knows for sure. So trust him, ask him, listen to him, and respect him. Whether you liked it or not, whether you agree or not, MAiD is here, and it's here to stay. I will never apologize for being involved in MAiD. I don't have to. And that's my job. I can apologize for one thing. It's my English. I hope it has been understandable for you, and I thank you very much for your attention.